to, okay, let's say there's a vaccine. So Big Pharma has come up with a vaccine for Mpox. And so the CS has gotten wind of it and wants us to vaccinate people. What will you're the health financing people, the DHPT people, how will you arrive at how much do we need? So there's a vaccine. This time we won't get donor funding. We have to pay for it ourselves. How much will we incur? What will you have in mind as you're saying a lot? What do you have in mind?
I can say how many cases you have so far.
And
maybe have like some kind of projection
in
terms of maybe how many cases would we expect to actually come out as a result of this infection.
How will you get that? Estimation. But we've never had Mpox before.
See, let me check on what WHO has for its models. Then you customize it according to your needs.
And so she said how many existing cases, so prevalent cases, and then incident cases you'll get from like sources like WHO. And then how will you arrive at how much do we need? How much?
Look at the literally need the HPTs, the service. You need to quarantine those guys. So there's human resource, there's the health product, there's the service itself, there's transportation also, and then there's the quarantine.
Yes.
You look at the direct costs.
Yeah.
The direct costs.
Related to that particular incident.
Yes.
Yeah.
Let me take you back. Why is modeling important? We've done decision tree, we've done Markov models. Timekeeper, why is modeling important?
It's important so that at least through, as they have said, after doing all those analyses, that you can be able to pull the resources. Whatever budget that you have for
Yes.
education.
Yes.
What can you be able to look into the budget and either forgo because of these other which has come like an outbreak, so that you can consider.
So it's important, as you said, so we can be able to, like project how much resources do we need, and because we don't have all this data yet, it's what we were trying to do while modeling. We don't know, we've never had Mpox before, so we don't know the probability of transitioning from infection to, let's say, complication to recovery. We don't have all that. But then we can extrapolate and borrow from other sources and put this in our model, and then that can help us
Take care of uncertainty.
exactly take care of the uncertainties. Indio. So we'll get into budget impact. It's something that you've always done, because you guys have done GO, hepatitis vaccine for 10-year-old girls. Before they decided to roll it out, they must have arrived at a budget to see, can we afford it or not? So it's things that we've always done, and we've always used data, only that now we're doing it like more scientifically or systematically. Sawa sawa. So that's, in a nutshell, what we'll be doing. It's like I've lost control. So this is the overview. We've already covered cost effectiveness analysis. So we look at budget impact analysis, the framework for thinking about budget impact, and then how to design budget impact analysis. So around the world, especially like in countries that are really advanced in HTA, they're saying it's not enough for you to tell us that something is cost effective or not. You remember where we stopped at Markov model, where Tabitha said, okay, so the CS wants to know, is it cost effective or not? So that's not enough. We want to know the next step, can we afford it? Cindio, like is it, like, okay, sawa, it's cost effective, or it's not cost effective, but can we really afford it or not afford it? Because something can be cost effective, but we can't afford it, Cindio. So that's the essence of budget impact. So nowadays, for example, like Thailand, they've included a request for budget impact analysis prior to approval for reimbursement, sawa sawa. So we've done a lot of cost effectiveness analysis ever since we started the training. So we're looking at, is it good value for money? But for budget impact analysis, we're looking at, okay, is it affordable? So this is useful, as Kevo said, for budget planning, for forecasting and estimating the budget holder's affordability. So there are so many guidelines that exist for conducting budget impact analysis. There are ISPO guidelines, country-specific guidelines, and we have access to all this. We can always borrow and tailor them to what we need to do in our country context. And so it's the same thing that we've done over and over again. So there's the intervention part of it, Sindo. Wait, the current state, the comparator, Sindo, the current environment, but there's what we are suggesting. So the difference will give us, okay, so what's the budget impact? Sindio, the total cost for this versus the total cost for this, what's the budget impact? Sawa? Because if we remain with the status quo, for example, in the other example we're doing for Markov model, we don't introduce a drug. What's the cost? Now we have introduced a drug. What's the cost? So what's the budget impact? Sawa, sawa, for introduction of this new intervention. Sawa? So how do we conduct a budget impact analysis? Usually, it's a continuation of, and even in the models, it's a continuation of, you remember the data that you already generated? It's actually what you're going to use to do the budget impact. So we need the same things again. From whose perspective are you doing the budget impact? For us, it's from the provider perspective. Sindio, what's the time frame? What's usually the time frame for planning budgets? 1 year. MTEF inakwanga? 3 years. Yes. So we need to consider what's the time frame, Sindo? What's the target population? What are the scenarios you are comparing? A new technology versus status. And so on and so forth. So those scenarios have to be very clear. The cost for each, and then now the modeling, because that will help us in the calculation. And then we need to input all these sources, all this data. It needs credible data sources. Someone mentioned about how do we handle uncertainty. And then lastly, what will be the reporting format? So BIA, as the name suggests, usually takes the perspective of the budget holder. And it's a short time frame, usually 1 to 5 years, depending on exactly what you're looking at in this case. For example, was it projected how long we're going to be giving 10-year-old girls HPV vaccines? From the onset, was it projected how long 10-year-old girls will be vaccinated? But are they still vaccinated? Yeah. Had it, for how long? Was it in perpetuity, like until 2030? Had it been determined yet? No? Not yet? Continuous. So again, depending on which guideline you're using, discounting may or not be recommended. So it's different. So this is what we look at. We have to define the target population. So let's work with an example. Give me an example. Mm-hmm. Yeah, we can say the girls were getting the HPV vaccine. So what was the initial practice? No vaccination. Sindio, the new intervention is vaccination. So the current practice, the way it was, they just say, Sindo, nothing happens to them, no intervention. But then for this other one, we'll give an intervention. So it's a bit different because it's a vaccination. So we'll use both examples. Let's give an example of what we were doing earlier, where there's an infection and then the intervention is a drug. So if there's an infection and then the intervention is a drug, Sindo, the current practice is wakae tuna infection. Do they incur costs? Yes. we now introduce the drug. Are there costs? Yes, sindio. So again, we'll compare these two outputs. So we'll use the same model structure, but then depending on what it is, I was showing Clara a more complex, so models can change. I think Tabs will send it to me and then I'll show yet another model for diabetes. Again, diabetes is complex, so people can transit like this. You know, like it's very complex. We'll show the model. So again, depending on what, I wish you had an exercise for you guys designing models, you know? Yeah? Not today. Yeah, because it's different for, you know, different diseases.
So when you say it's complex, are you referring to the different health states? That they can be more than even 10?
Yes.
At some point?
Yes.
So it becomes very complicated?
Yes.
Okay.
Some can relapse, some can, you know, like move. Yeah, it can be quite, yes. PhD. Yeah. And then what are our inputs? We said, for example, for mpox, we need what's the prevalence, what's the incidence. These are data that we need to input into a model. We need to consider both direct and indirect budget impacts. You can introduce an intervention and the budget impact is beyond just that intervention. For example, you give no, which example? Let's see. Which one? I'm still trying to think of mpox. Okay, to come up an example for indirect causes. So we talked about handling uncertainty. That there could be differences in proportion of patients, Cindy. There could be differences in the coverage, in the drug uptake. So it's different things, and we need to account for. Is there a class for handling uncertainty? For probabilistic sensitivity analysis? Those things? Okay. Yeah, because it's another topic on its own. And then lastly, the reporting format. You can either decide to aggregate the costs, like for every year, or to disaggregate, depending on, for example, if it was for 5 years, our budget impact analysis, we can present each year on its own, or the total for the 5 years. So we'll get to the exercise, but then because of time, we'll do it all together. We'll do it all together. What was a perfect example for the model that, okay, it's still showing my, I want to show the Excel. What was a perfect example for the model that we were using in the morning? Not in the morning, after lunch. Hey. Malaria. Sawa. Malaria, alisema, malaria you can get infected again. Yet, but our model didn't have, yes, so we can use chickenpox. Yeah.
Sorry.
Umekunya mingi mkasahau. There's a model. Do we have prevalent cases for chickenpox? Someone search for us. Nione kama hata mmejua searching. Kwa PubMed. Bado niko na chocolate by the way. I want. Nataka munipatie 2 things. In Kenya, prevalence, yeah, chickenpox, na incidence. That is very fast. Thank you. Alafu sasa kila mtu aniambie figa yake tushindwe sasa. Depending on the source. Source gani kwa Google? Mtu aniambie na niambie source yake. Wikipedia. Wikipedia in a rank at what level your sources? Is it a good source?
No,
The lowest of the lowest. Hey, okay. Prevalence of chickenpox? Yes.
I hope government
Hata wamesikia chocolate wakachanga. I can't even hear figures, like even, I'm even expert opinion. You guys are the experts. Sindo, you'll estimate it to be?
of chickenpox in Kenya.
Prevalence of chickenpox. Is it that hard? Could we use another example? Sawa. Epidemiologists. How are you, Ko? Scientists. Kila mtu, eh? But how will you use consumption for something that does not exist, like mpox?
Yeah, then we have to use the
Yeah. And she said they use consumption, then namuuliza, but how will they use consumption for something that does not exist, for example, mpox? Something very new. Hey, okay, so we'll have to use dummy figures. Do they exist somewhere and you don't know? But you can take like an hour searching for, it happens. Even probability, remember that we presented, we already had inputted probability for you guys.
Yeah.
Hey.
Oh, yes. You have to look at studies.
Yes, to get probability from this state to this state. Mm. Okay, so we can just use a rough example. I think we have like 10 minutes. So for example, okay, you're so determined. Okay. Everybody look up. We'll use hypothetical figures. Sam, just what do you think is the prevalence? 1%, 5%, 0.1%. Chickenpox. Yes, Kenyan population. Whatever you say is what we'll use. Expert opinion. 2%, sawa. 2% of 50 million. Two percent of 50 million? Yeah? Yeah? Okay. We'll use Brian's example. Good, so 1 million. Brian, mathematics. Sawa. Look up. So we do it together. So 1 million. Cindy, that's our prevalence. We're using the same model that we had used. Cindy, so what's a budget impact? A baseline, like if we don't do any intervention, let's say there's no vaccine that exists for chickenpox yet. Cindy, so this will be the cost for the first year. People have the infection, it will be 10 billion. 10 billion. 10 billion, right? Versus if we now introduce a vaccine, what will be our cost? What's the cost? 1.15 billion. Sindo, and that now because we've included the cost for the drug and OCG distributing it where and sawa sawa. Wait, these are the direct costs only, sawa. Aya. For the second year, look at the remarkable difference between baseline and the drug in the second cycle. 29 million versus 2.3 million. How would you interpret that? So we're using the same Markov model, this one, Cindy? Yes, so all that we have changed is the number that 1 million people have chicken. That's a prevalence.
The cost of the drug is as per like
The cost of the drug, the cost of the vaccine is 1,500. Sawa? Yes. It's already factored. You remember, let me show you where we'd put it. In the formulas, Cindy, you remember Tabitha took you through them? Here, the cost of the vaccine. Sawa? So it's already there. Well, how will you explain those differences? Like at baseline, it's 29 million. Now that we've introduced the vaccine, it's 2.3 million. Our total cost. So is our intervention cost saving?
it is.
It's cost saving, Cindy. Yeah. So basically, if we are to calculate the budget impact, what time duration do you want us to use? Minor? Tutumia duration, yeah? 3 years. Good. So we'll take this, the first 3 years. We can input them here. Let me just paste the values. So this is for the comparator versus for the intervention. They're actually here already. There's a way I'd linked the cells, but it's okay, let's do it together. What are the costs for the intervention? They're here, Cindy. Minor has said project for 3 years. Oh, gotcha. That's why I wanted to use the values instead. Okay, let's paste the values. So, and then the incidence. Some gave us a value for the incidence, for the prevalence. Chatone nani atatupatia ya incidence. Aida, incidence of chickenpox. Prevalence is 2%. Incidence, Gatukui. Yeah? I guess, Athanasio, incidence?
Just take
half of it. 1%. What's 1% of our population? 500. So no, 500,000, right? Okay, so we input 500,000. And then we take the costs. Copy. So for this ones, I would want to transpose like that. Okay, let me do it. I hope you're able to follow. So I want to paste values, but then to also transpose them. So this is for year 1, 2, 3. Sendo? But then this will be the cost in the first year. Sindo? We've taken the cost right now for the next 3 years. Sindo? For the incidents. But next year there'll be new people. Does that make sense? Wait, does it make sense?
Yes. There'll be new people. We are sure that it will actually spread and we'll have more cases.
Good.
It's like we are anticipating that we will actually have more cases.
So the prevalence plus the incidence, Sindo, again. So we come and put them here. And the third year as well. And then you repeat that for when you have the drug. Are you able to follow? We would have done this exercise kila mtu peke yake, but then because of time, that's why I'm doing it. Aya. Hoping this can transpose as well. Yes. So if we do it like that, then what's our budget impact for the first year? This plus this. Does it make sense? I've lost you? Mm-hmm. Yes, Aya.
Maybe can you just go step by step so that we understand what the figure.
So we estimated, Sindo, that we have a prevalence of 2%. Sindo, 2% of 50 million was 10 million. 1 million. 1 million. Huh? It's 100,000.
2%? When you're right. Or 50 million? It's 1 million.
Okay, calculator.
Excel will be okay. It's equals to, and then that one, and then 2% of 50 million is 1 million.
But I already said that then 50,000, 500,000.
Yeah.
It's 2 million, sorry.
It's 2 million, yeah.
Is that 50 million? Yes, it is.
It's 1 million.
Yeah, it's 1 million. Sawa, Brayo. So tumesema prevalence of 2% yeah, chicken pox. It was an estimation because we couldn't get it on PubMed. Yes. And then the incidence, 1%. Sindio? Yeah. So the moment we input here 1 million, and then we get the costs for the, let's put it again. Is that 1 million? Yes. And then it calculates the cost automatically, Sindio. So we get the cost for the baseline. Minor said we calculate for 3 years. It is fine to go with the MTF cycle higher. And then the cost for the drug, the vaccine, Sindio, with that intervention, those 3 years, Sindio. So it's what I've put here. Sawa. So just to the prevalence, then you can tell what will cost us more. Let me insert so that it's not too crowded. Okay, wait. Remember when you said you can either report it as an aggregate or as disaggregated for every year. So if we aggregate for those 3 years, that's it. Wait. Yes. Kwa nini nasema spill? Some. Now this ones will need commas to understand. It'll be 10 billion, Sindo, if you're only to consider the prevalent cases. Versus the intervention, oh, huge difference, Sindo. So had we not introduced the intervention, which is the vaccine for chickenpox, it will cost us 10 billion. It will cost the Ministry of Health, the government of Kenya, 10 billion. Once we introduce the vaccine, it will only cost us 1 billion, right? So that's a huge cost saving. Yet, in this one, we've considered the cost for the drug. So our budget impact, without any intervention, is 10 billion. Our budget impact with an intervention, which is introduction of the vaccine, is 1 billion. So what's our cost saving? So should we introduce the vaccine or not? Yes. And then we put this funds elsewhere, Sindo, like we've made a saving. But then consider that every year, there are people getting infected upia, right? Like the incident cases. We hadn't included them here. Sindo, that's why we're doing yet another calculation down here for incidents. Sawa? Haya. So we said the incidence is 1%. 1% of 50 million was 500,000. Huh? 1% of 50 million is 500,000. So we put it here, 500,000. Higher. We take the costs. Sindo, again, minus 8, 3 years. We take the costs for the drug and for no drug. This one, for the baseline. Sindo, for no intervention. It's what I was copy-pasting here. Higher. In this first year, we only have these cases. In the second year, we have the cases for last year and the new cases. It makes sense? Yes. Cumulative. In the third year, we have the ones for the first year, the second year, and the third year. Now, instead of putting the numbers, I'm putting the costs. Because I've put the numbers here anyway. Sindo, the number is here. It's right here. Sindo. So I've just taken the costs. Which means then, in the first year, we'll incur this much for the incident cases. But in the second year, we'll incur for the incident cases for last year because we've had to add kwa prevalence. So it's these ones plus this. For the second year, the ones for last year and the ones for this year. In the third year, the ones for the last 2 years plus the ones for this year. That's what I was doing here. And then, so this is the total. Sindo. For the first year, it's, wait, how come? Has it changed? Like it should be this figure. Oh, okay, I've understood. But instead of doing this, we can just add over here. So the total then will be this one, Sindo, plus this one. Make sense? Tuko pamoja? Yes, for the second year it will be this one. It's a sum, sorry. So that will be the impact on our budget. So what's usually the shortcoming when you're doing it kawaida? Do we consider both prevalent and incidence cases? It depends on the, It depends on Carol?
I think it depends on the disease at a particular point.
Yes.
But I think most of the time, like when I was in TB program, we used to consider prevalence and also estimate for like having maybe new cases or new infections.
Yes.
Yeah, I think it depends on the program.
It depends on the program. So TB, you were able to consider both the existing cases and also to project.
Also plan for any new cases that might come up.
Yes.
Yeah.
For, what was that other example? For hepatitis B vaccine. Lucy, what did you consider? Population growth. That the number of 10-year-old girls at that point won't be the same. Yes.
HPV, not hepatitis.
Okay, wait, HPV, yes. For hepatitis, let's go back to hepatitis. For hepatitis? Did you consider both prevalence and incidence?
No, we're just considering the health workers who are at risk, the people at risk.
And was the number increasing like every year? Yes. Yes. So that's basically what we do. So we can clearly, so it depends, again, that's why Tabi was saying, like garbage in, garbage out, because you'll use the same model for budget impact. So if you design it very well, then all you're changing, as you saw, is the figure. Now it won't be infection per se. Cindy, it'll be whatever else. Yes. So when you change here, then it automatically gives us the costs. And so you take those costs, bora tu you consider both the prevalence and the incidence cases, and then you see, okay, for example, let's come back to this. Based on our budget, like the Ministry of Health budget, can we afford 10 billion? Wait, what was it? 1.1 billion for chickenpox vaccine. Yes, it's too expensive. So as much as this intervention is cost saving, and had we plotted the CEA curve, where would you think, which quadrant do you think it will have been? Okay, the plane. The plane? Okay, does anyone remember Sarah? Hey, okay. Do you remember the CA plane?
Is it
Cost effectiveness plane, yes.
Is it a plane?
The 4 quadrants, do you remember?
The four quadrants.
Yes.
So societal,
Yes.
another thing.
No, see societal. Do we get back to it? Oops. So I just want to show that as much as that intervention would have been cost effective, it's not necessarily affordable. Cindy, because you said, hey, allocating 1.1 billion at the ministry for chickenpox vaccine. It can't happen. Cindy, exactly. So as much as something has value for money and it is cost saving, we've seen the difference. Indio, this minus this, it's saving us 8 billion, but still, can we afford 1 billion for chickenpox vaccine? No. That's where donors come in. What else can you do apart from donors? What else? Raise taxes. Eunice? Like what? Something else that you can consider, price negotiations. They're selling 1,500 per dose of chickenpox vaccine. What if we negotiate with the supplier to sell it at like 500 shillings? Will we be able to afford it? Cindy, things like those. And then when we were doing the prevalence and the incidence, we looked at the whole population. Cindy, maybe then we can focus on a target population. Cindy, will that reduce?
Of course, it will, because the number will reduce.
Yes.
Yeah.
So, and that's why at the beginning we said, like, normally cost effectiveness studies are not enough on their own, because had we just concluded on, okay, it is cost effective, we want the government to implement, but then is it affordable? Sindo. And then we've clearly seen, okay, it might not be affordable. Sindo. And so as you're giving feedback to the management, then you're not just saying, okay, it's cost effective. Sindo, you're saying, okay, it's cost effective, but it'll have this impact on our budget. And we just don't stop at that. We can say, okay, what are some mitigation measures that we can put in place? Can we negotiate for the price? Can we seek donor support? Can we raise taxes? Can we, what did you say? Give it to a certain group of people. Exactly. Sawa, sawa. Yes. Any questions? That's budget impact. There are things, let me throw a spanner into the works. There are things that might not be cost effective. Which quadrant will they be in? They're not cost effective, but maybe they don't have too much impact on the budget. They're not cost effective. Remember those examples we had yesterday? Yes. Timekeeper, we can end at any time. This is just an open discussion.
Which ones again? Societal?
Eh? We need to go.
There was fair.
Yeah.
That we head out for dinner.
Yes.
But yes, we can have that discussion.
Yeah, but we are done. So, Aya, let's think about, is there an intervention that, so intervention versus comparator, Sindo, you do all those delta cost, like incremental cost over incremental Kali, the intervention is not cost effective. But when you do budget impact, it's affordable. Like maybe it will only cost 10 million. What do you do in such a case? And let's think of what will have, what will be an intervention that's like that, not cost effective, but not too much impact on the budget. Remember, okay, let's give an example of an intervention that will be. Remember those examples we had in this paper yesterday? Not cost effective, like that one of 200,000. Which one was it, Dr. Ewak? So it does not have too much impact on the budget, but is it cost effective?
There's this one that is not cost effective.
Okay, there's that one. Remember, in yesterday's example, there was an enzyme therapy. Yes, for Gaucher's disease. So the budget impact is 10 to 16 million.
No, I don't know the example.
Nancy. A good
We're
one.
discussing these ones for yesterday.
Okay, sawa. Is it this one? Ama there's another one.
If I remember.
Was it 10 million? Yeah.
Yes, we can discuss this one, Cindy.
But the ISA was very high.
So the ISA is 40,000. We said hypothetically, in this example, our threshold was 5,000. So this is not cost effective. It is 40,000. But the budget impact is only 10 million. It only takes 10 million of our budget. What do we do? Humanitarian.
And the comparator what?
So the comparator,
It was what? Yeah,
Palliative care.
yeah.
But again, the number of patients was just 5 to 8.
5 to 8 patients.
And sometimes you can include that impact is too low.
The impact is too low, but it's not cost effective. So what do we do? Yeah. So again, those things go hand in hand. Ndio, you can't think of them in isolation. Tunaenda sasa. So it's not enough to just do a cost-effective analysis. It's always good to accompany it with a budget impact analysis. And on the other hand, what we've always been doing, just doing budget impact analysis. And we don't consider so much the cost-effectiveness analysis. So it's important to do them all together. Sawa?
I've missed that one. What we do and it's cheaper. It's less.
Impact on the budget.
Yeah, but it's not cost effective.
Maybe another question. Or put it this way.
Yeah.
For a long time,
Yes?
for a long time, NHIF, we don't cover for quite a number of the screening tests. Sindio? But we pay for the
Treatment.
oncology treatment.
Yeah.
Which is very expensive.
Which is very expensive.
Yeah. So if you had screened,
But
maybe the
had you
cost would have
screened,
been-
Sindio, you would have.
But
So had you,
that's a good example because
sijui niwapatie assignment
to complete it, when you screen the
to draw like a model for such a thing.
sensor, so it's so expensive. On the budget, it's very, you cannot even meet it. But treating those few cases is not
No assignment. Leo ni sherehe.
that's a very good example.
And you avoid the cost effective.
Yeah,
Because you're thinking it's enough. Yeah.
very
Something like that.
Yeah. Okay, sawa. Dinner time. Dinner time. Dinner time. Yeah, the two of them. The two of you have homework.
Yes.
Yeah.